Okay, I think we'll get started. Hello, everybody. Hopefully you are intending to hear about the outreach with the Health Specialism Test and Learn project. This is a 1 hour webinar where you're going to hear from us about what the project is, how you can apply, how it will be evaluated, and you're going to hear from our partners at CGL, who are going to be the people who deliver the intervention in your area if you put yourselves forward and are selected. So my name is Michelle Binfield. If you can move it on, Guillermo. I am the program director for Test and Learn and the systems wide evaluation project. And you're going to hear from these good people on the call today, or they're going to be around working on this project in the background. I won't ask everyone to introduce themselves now, but maybe when they speak, they can introduce themselves. You're going to hear from Rebecca, who's going to talk through what the project is, what we're looking for. Guillermo, who's our Director of Evidence and Evaluations, who's going to talk to you about how the project will be evaluated. And like I say, Leslie and Jazz from CGL. So we're all going to sort of present some of these slides to you as we go along. Some nice pictures of us there for you to take away. Some housekeeping. These slides, we will send them around after the webinar. And if you go to our website, I think we'll put the link in the chat for you. You will find a project brief and other documents and a copy of this webinar on our website. It's being recorded, so you'll be able to watch it or send it to colleagues if you think they need to see it after the fact. This is the last in a series of webinars that we have been running as CHI, showcasing the opportunities to get involved in the individual test and learn projects. My apologies if this is your 7th or 8th webinar, because you're going to hear some duplicate information at the start. We have to go through everything, obviously, just in case there are people here that haven't attended any of the other webinars. After we finish presenting, telling you all about the project and the opportunity and how to apply, there'll be time for questions and answers. There usually is when we do these webinars. Please use the Q&A box and not the chat. We can't see the questions if you put them in the chat, or we can't respond to them. You'll see at the bottom of your screen, there's a little Q&A button there. It'll open up a box for you. So if you've got any questions, do put them in that Q&A box. I'll be keeping an eye on them as the presentations are going forward. And then when we get to the Q&A, we'll put the questions to the relevant members of the panel. So thank you. Next slide, please. So in case you don't know about the Centre for Homelessness Impact, the organisation was created in 2018. And our mission really as an organisation is to act as a catalyst for evidence-led change. So all about evidence, what works, supporting government and policymakers and commissioners to derive the most value they can from the money they put into the system, by making sure that any interventions, any projects, any work we do, we know it works, and we know where to put our money for best impact. Our goal as an organisation is to ensure that policies and projects to tackle homelessness are as effective as possible. And we want to work collaboratively. We don't have all the answers, but we work collaboratively with lots of people: academics, evaluators, service delivery people, people with lived experience, all sorts of people we'll collaborate with internationally and within the UK to try and understand and share information and evidence about what works. So, as I've already said, policymakers and practitioners can really use that information and that evidence to create impact. Thank you. So obviously why we're here is a sort of very exciting programme, really, with two elements to it that the Department for Levelling Up Housing and Communities committed to in its 2022 Ending Rough Sleeping strategy. In that strategy, DLUP committed to investing £15 million to improve the evidence base that exists around rough sleeping, to try and understand and create some real examples of interventions that could be very effective, and test interventions to see if we could be doing more of one thing and less of another. It's an ambitious commitment. It's the first time it's been tried in the way that we're doing this programme. And it's an important investment in trying to improve the amount and quality of the evidence that exists in the homelessness and rough sleeping space. So as I said, within the program, we call it a single program, but there are two very distinct elements to the program. And it's taken me certainly a few months to get to grips with it all. And we hear the language and we hear the words, and it's hard to understand it. So the test and learn is, from my point of view, a bit easier to grapple with. So it's the first ever program of trials, basically projects, interventions, trials in the homelessness area in the UK. So we're going to be testing 8 different interventions, testing, delivering, evaluating interventions which we think might be able to make a difference in ending rough sleeping and preventing homelessness. The test and learn programme is an opportunity to really properly evaluate and properly test whether those interventions work. Many of them are interventions we might have already had in place, in lots of different areas over the last few years, but they've never been rigorously tested in the way they're going to be as part of this programme. The second element of the programme, and very exciting, is something called the systems-wide evaluation, which is a single sort of project which is intended to identify opportunities for systems-wide improvements or systems-wide change in homelessness and rough sleeping. We're not going to be talking about that today, but if you are interested in that, there's lots of materials on the website. It looks at homelessness prevention, rough sleeping initiative, rough sleeping accommodation project. It looks at all the system levers, factors that affect and influence rough sleeping and homelessness, with a view to seeing if that system could be improved. Thank you. So test and learn, some key principles that apply across the board. I'm going to hand over to Rebecca to talk specifically about the outreach with health specialism projects, but just generally, in terms of key principles, there's 8 projects here, and we could have done 80 if the money had been available. So we had a long list of projects, lots of ideas from people like you on the call today, local authorities, practitioners, also academics, all sorts of people contributed their ideas. And there was extensive sort of co-creation and a sort of distillation of that massive long list of projects into the 8 projects that we've taken forward. There's a real sort of representative spread, some that relate to data, personal budgets, employment, migration issues. This one relates to health. So the 8 projects were carefully chosen with DLUC and with the sector. Although 15 million seems like a lot of money to spend on a sort of research programme, especially when we've got increasing levels of homelessness, it should be noticed that most of that 15 million is actually being spent on service interventions, as you'll hear from CGL shortly. A big chunk of the money, the vast majority of the money we're going to spend on this trial, is going to be spent on employing actual nurses that are going to do actual work with homeless people. So there is an element of that 15 million that's spent on the evaluation, but by far the majority of the money is being spent on the services that will help people who are homeless in the here and now. As I've already mentioned, one of the key facets of this programme, what makes it exciting and what sets it apart, is that the projects will be independently and very robustly evaluated. That evaluation will be managed by CHI, by Guillermo. You're going to hear from him shortly, but it will be conducted by partners who have got tremendous experience in this kind of field. And Guillermo will talk to you about that when we get to that part. And although we can't deliver these services in every area, if you've already got a nurse in your outreach team, what we do in this space and the test and learn project with this very robust evaluation will also give you material, evidence that you can take to your commissioners or your local health body or whoever's funding your nurse to get them to carry on. So although we are going to be evaluating a set number of these interventions, we do know they exist in different forms, in different ways in lots of other parts of the country. And what we managed to develop through this project will be of use to you, we hope. And I think the reason a lot of the conversations we've had is where people have said to us, why are you setting up new services? We already have this. We already have a nurse in our outreach team, or we already have this kind of intervention and you're going to be testing it. And I think what's important about evaluating something from scratch, from the very beginning, and setting the conditions through which you can robustly evaluate it, agreeing the baselines, the data, is that you're going to do that much more thoroughly and in a way that prevents much stronger evidence to funders going forward. Certainly in my other role, we've set up projects and we've not thought about evaluating them properly from the very beginning. We decide halfway through we should have evaluated it in this way. We're not going to make those mistakes with these trials. Next slide, please. Finally, I think this is the last from me, I'm not quite sure. The test and learn timeline, we've just set it out on the slide for you there. It's quite a long project. It started in the autumn of last year and it runs until 2026, well into 2026. We're at the phase 2 part of the test and learn timeline now, where we've launched the project. So we developed all the specifications for all of the projects and trials. We've engaged with partners. We are opening up an application process for people to apply, to have the projects in their area, to either apply for the funding or to apply to host a project. And we are setting up services. So by the end of June, we'll have been in a position where we'll have opened up all of the test and learn projects, selected partners, and we'll move into a more implementation phase. Next slide, please. These are the test and learn projects, just a sort of snapshot of the 8 of them there. Outreach with the health specialism is the one we're going to talk about today. If you're interested in any of the others, as I said, if you go to our website, we'll put the link in the chat, you'll find dedicated sections of the website for all of these projects, and there'll be a recording of the webinar. If you weren't able to get to any of the other webinars, you can watch it from the website, and there's some documents that describe what the projects are. Some of them are already open for applications, so do be aware of that. If you are interested, don't hang around, go and have a look at the website as soon as you can, otherwise you might miss some opportunities. Next slide, please. I'm going to hand over to Rebecca now to talk you through the key features of this project. Thanks, Rebecca.
Okay. So we know that there are several outreach teams that now include staff with a health-related specialism, and the aim of those is to address the health needs of people sleeping rough. However, as Michelle has already discussed, we don't know the impact on rough sleeping, and it hasn't really been robustly assessed. So the health specialists that exist within outreach teams at the moment, they're engaging differently with the person. So it can be to open routes out of rough sleeping, bring specialist knowledge to support people's health needs and helping people navigate the mainstream health system. So for this project, what we've done, we've commissioned Change Grow Live to recruit and manage nurses that will be embedded within outreach services. So we're seeking to identify local authorities that have an outreach team that would benefit from the inclusion of a nurse and who could support the implementation of this project and host this role. So the nurse is expected to be a full-time member of the team. They'll be expected to complete regular shifts with the outreach team, have sufficient qualifications and experience to deliver episodes of care, manage a caseload, and support access to mainstream health services. They're expected to be Band 7 nurses. So the service will be delivered in 8 areas, and it will be delivered for a duration of 18 months. And areas who are hosting the nurses, they'll be expected to work with CGL, who have got the relevant expertise to recruit and support the new members of staff. And that will include clinical supervision, risk management, etc. And they will be supported by the project implementation partner, who has got expertise at delivering these types of services. And that partner will work across all the trial areas, setting up new services, and will offer advice on the policies and procedures, will deliver some training and do some sort of general quality assurance. But they will also be key in facilitating a community of practice as part of this project. So I'm going to hand you over now to CGL, who are going to go into much more detail about the model itself.
Thank you, Rebecca.
Thanks, Rebecca. Hi, everyone. I'm Leslie Howard, and I'm the Head of Homelessness for Change Grow Live.
Hi, everyone. I'm Jazz Chamley. I'm the Associate Director of Nursing for Change Grow Live.
So it's a little bit busy, our first slide, but we're not going to talk through all of it. It was just to give everyone a bit of an overview of the structure within Change Grow Live from our chief exec, and then you know, I sit under our executive director who oversees some of the specialist services. So I sit under her as head of homelessness, but also she looks after director of inclusion and the head of probation services. Jazz, did you want to speak a little bit about yours?
Yeah, our clinical side of it, we sit under Fun Balraj, who is our medical associate director, executive director, and within that we have our nursing director, who is Denise Burridge, and beneath Denise is 3 associate directors of nursing, covering the whole of the UK, and me included in that. And underneath that, we have regional lead nurses. We've got 7 nationally that cover the country. And within that, we have also lead nurses and cluster lead nurses that sit within individual services. So we have about 50 drug and alcohol services. And in addition to that, we have homelessness outreach services as well. We also have a national harm reduction lead and a national hepatitis C lead as well. We've also got our associate medical director, Lahini, and our director of pharmacy, which is Mohammed Bessel. And below that sits the medicine management pharmacies. And with this, there's 5 of them nationally as well. Now we've also got our director of integrated practice, and she looks after the head of social work and the head of psychology and psychosocial therapies as well. And then we obviously got our other exec directors that look after our operational directors as well. You can see.
Next slide, please. I think you might have covered most of your next slide, Jazz.
Yeah, so this is going to give you a bit more of an idea of our clinical arm. And like I said, we've got our executive director there at the top, director of nursing, associate director of nursing, which is us. And I've sort of said a lot of that. Director of assurance, we've got Sarah Whitaker, and the medicines management team there as well. We currently have about 430 nurses nationally that we support. So we do have our central teams, which is your director of nursing, associate director of nursing, and regional lead nurses. But below that, we have our nurses that are linked to individual services as well.
Thank you. So as head of homelessness, I oversee all of our homelessness and outreach services. We have 7 standalone outreach services and another 23 services funded through the Rough Sleeper Drug and Alcohol Treatment Grant. So lots of outreach taking place every day across the organisation, and some of the Core Street outreach services we've had for a very long time. So our Camden service we've had for 20 years. In fact, it'll be 21 this year. So we've got a lot of experience in delivering those services. Underneath myself is the Homelessness Services Cluster Manager, Ryan, who works very closely with our 7 street outreach services. So he manages the managers of all those services. So we've got a really close eye on what's going on every day within the projects. Next slide, please. So to give you a little bit of idea of how the nurses will be working, there will be out of hours working, which will include early and late outreach sessions. They'll take part in the street counts. So the nurse will be embedded within the outreach team, which obviously is not necessarily a Change Grow Live outreach team, but they will work alongside that team, taking part in the street outreach sessions on a daily basis. Although there won't be lone working on the street, there might be times when the nurse might visit someone in hospital. There might be that type of lone working, or going to see someone in a night shelter, a building-based service, basically, where they could be completing some of their work. So based within the local street outreach team, as I say, it doesn't have to be a CGL outreach team, but there will be a CGL hub nearby where the nurse can get their clinical support from. Working from other sites, as I've mentioned, they might be holding surgeries in sort of day centres, hubs, visiting the night shelters. So it won't all be on street work. It would be the same as it would be for any of the outreach teams, going to different partnership agencies to connect with people that are homeless and sleeping. So they will have, for example, they will have laptops, they will have the phones. There's potentially some other equipment that might be related to the nurse outreach that a regular outreach worker might not carry. Well, we did discuss this and how heavy the rucksack might get, so we'll be looking into what they need and what they don't need to be carrying, but appropriate medical equipment that they might need when they're out and about on the streets.
So the infrastructure and support, what they'll get is the oversight from the CGL Nursing Director and the Head of Homelessness, which is Leslie. And like I mentioned, we do have our national and regional forums as well. So we have quarterly forums that we hold for all nurses nationally, and all healthcare assistants and nurses do attend, and they get some sort of safeguarding training within that as well. And then there's a homelessness and outreach first-time workers managers networks, which Leslie runs, which is held. How often is that held, Leslie?
Monthly. So they're monthly meetings. So they're very much about bringing the workers from all of our outreach services together on a monthly basis. The first line network is obviously for those frontline workers to come together, and then there's a managers meeting as well. And we'll have relevant training in those meetings. So we might bring someone in to do some training on cuckooing, or we might be talking about rough sleeping statistics or any challenges that people are seeing. But it's very much about bringing people together to discuss some of the challenges that they might be experiencing, and some of the solutions and best practice that we can share.
So clinical supervision will, can we just go back? The clinical supervision will come from the project managers. So there will be 8 nurses, and the 8 nurses will be managed by a project manager, which will also be a nurse, who will be able to provide that direct clinical supervision. But in addition to that, as the nurses will be linked to CGL hubs, there also will be a lead nurse or a cluster lead nurse there, where they can also get a day-to-day supervision if needed. And the project manager will be managed by me, and my background is that I am a general nurse as well. And there's going to be safeguarding support as well, which is overseen by our head of safeguarding and quality, where they can attend pods for safeguarding. The safeguarding is included in their statutory mandatory training as well. And each service does have a safeguarding lead as well. So if there was anything that was a priority, they could go to that person as well for that. Induction and training. So the induction will be we give all our nurses a 4-week induction. So depending on what training they come with, if they come from an existing substance misuse service, they will still have the 4-week induction, but that'll be interlinked with the other outreach nurses across the CGL. And like Leslie said, we have quite a lot of outreach services and a lot of outreach nurses as well. And like we said, we'll have the nurse and healthcare forum as well. We'll have the homelessness thematic meetings, which are monthly. Leslie said before, we also have the First Line Workers Network, where they can attend the women's homelessness meetings and no recourse to public funds working group as well.
So they're specific. Sorry, Jazz, I was just going to say they're specific meetings to bring people together to talk about, those challenges. So we are coming together from all the services nationally to talk about, for example, how we support women that are rough sleeping, and looking at solutions and best practice on how we work with people who have no recourse to public funds or restricted eligibility. And there's also, I don't know if it's on this slide or not, but we have developed our own assertive outreach training as well, which covers dynamic risk assessing, de-escalation training, managing challenging behaviour, and just the assertive outreach model for Change Grow Live, which I know if someone's not based within a Change Grow Live outreach service, it might be slightly different in one of the other projects, but we'd be willing to sort of look at that when it comes to it.
And the nurses will also have access to our internal training. So we do have our Connect Skills, which got a lot of training out there for the nurses, but we also, all the nurses have access to the RCNI website, where there's a lot of internal training as well. And they also have half a day CPD in the month to enhance their professional development in whichever way they would want to. And we have also taken on. We've got some specific wound care training for all our nurses, not just our outreach nurses, which they have access to as well.
Excellent. So I think that this is the moment in which I can take over. So I'm Guillermo Rodriguez. I'm the Director of Evidence and Data here at the center. And basically my role will be to give all of the oversight to the research program. And I'll be working with evaluators really closely to make sure that all of the evidence that we can collect through this project is really, really effective and helping us make the case that this type of intervention is effective so it can be funded in the long term. So a couple of requirements that are really important for the evaluation, but also for how we are setting up the process. The first thing is, as Rebecca was mentioning, if there is already an existing service that has an outreach with a health specialism, this is not the program for you because we're trying to set up new services. Second thing is that the idea is that the outreach team will completely integrate the nurse so that they become part of that team and part of their usual activities in the ways that Leslie and Jess were describing. In terms of how to apply, we'll be having an expression of interest process where local authorities who are interested can put a bid. All of that will be done through our Flexi Grant program. And you will see that partnership bids are welcome, but in that case, they need to be areas that are really close to each other, for example, that are in the same health board. In terms of setting up, we're going to be working really closely with CGL to start all of this process in June of this year. And the idea is that the services will be ready to start delivering to people in January 2025 for a duration of 18 months, so until June 2026. I think we already covered the first point. So this is about making sure that you don't have this type of service. And of course, all of the organizations that need to be taking part will need to support not only the intervention, but also the evaluation side of how we are going to be commissioning and running all of these projects. So it's really important that as local authorities and the organizations that might be interested, you have all of the relevant approvals from your organization to make sure that you can comply with the requirements of the project in terms of data collection, in terms of data sharing, and of course, the relevant approval to put a bid forward. So make sure that all of the relevant people have sight of this project before submitting anything through FlexiGrant. Rebecca, is there anything you wanted to touch on this one before I go to the evaluation? So I covered most of these already. So it will be an expression of interest process, whereby we'll be selecting which are the 16 areas to take part in the project. Really importantly, we're looking for 16 areas in total. 8 of those will receive the funding and all of the support to embed a new nurse in their services, and the remaining 8 will form part of a control group, and I'll explain that in a second. All of those that are in the control group will receive a financial incentive to continue taking part and help us with the data collection that will be necessary for this project. The evaluation will be done by Cardiff University, who is a team that has both expertise in homelessness services and in homelessness research, but also have a clinical team that have a lot of the experience of making sure that these types of interventions that come from a health background can be implemented in other spaces in a way that is really robust, and making sure that the evaluations are aligned with the demands of those types of interventions. In terms of the dates, we just mentioned the key ones. The key thing that you want to remember is that we're launching the grant process on the 14th of May. So definitely add that date in your calendars, and it will be open for a few weeks. And after that, we're hoping to start proper delivery in January 2025 and have the final results for the department at the end of 2026. So in regards to the evaluation, which is the side I'm responsible for. So all of the evaluations that we are commissioning as part of a test and learn program will have 3 components: impact, process, and the economic aspect. So the impact is really trying to help us quantify whether the nurse embedded in the outreach team helps to make a difference in terms of the housing outcomes that people end up facing. The process and implementation is much more qualitative, and it's really helping us to understand what are, for example, the barriers and facilitators that can help us improve service delivery for the future. And the last one on the economic is about what that says on the tin, is making sure that we have enough information to outline whether the benefits of an intervention like this outweigh the costs of making this type of investment. Really, really importantly, and one of the things that makes the test and learn program so unique is that all of the evaluations will be done through the most robust mechanisms. So in this particular case, we're going to be doing something that is called a randomized controlled trial with randomization at the local authority level. Basically, in a nutshell, what this means is that we are going to identify 16 local areas that are really keen to have a nurse. And we're basically going to identify of those, we're going to randomize them into 2 groups. Some people are 1, some people are 2. Those areas that receive a 1 will be funded to receive the nurse and all of the support from CGL, and making sure that we can embed that nurse in those areas. Those that, in this case, receive number 2 will receive a financial incentive of £10,000, and they will need still to contribute to the data collection and the rest of the evaluation. It's really, really important that the control group really helps us to make the case that these types of investments can make a difference. So even if it's slightly disappointing to land on the control group, we completely understand that. It's absolutely crucial to make sure that we have a control group that is really robust, so that in the future, these types of investments can become mainstream and we can see them happen all over the country. So the other things in terms of the evaluation and what you can expect, of course, we will need to be collecting some individual level data, and both Leslie and Jazz alluded to these already when they were describing that the nurses will be expected to have tablets or other mechanisms to collect data, and that will be true both in those that receive the service and those that remain in the control group. So largely, we expect most of the data to be based on data that is already being collected by outreach teams. So we'll be working with all of the selected local authorities to make sure that we have a system that allows us to collect information as consistently as possible. Of course, there might need to be some adaptations, and there will be a period in the summer and before the setup to make sure that we got the information that we need and that is not as burdensome as really possible. That's also one of our key objectives. Second thing is that, of course, to enable all of that data sharing, we'll need to sign a data sharing agreement between DLUC, CGL, and the relevant local authorities. And we have been producing and working with the department in the templates that will facilitate all of that process. And finally, of course, one really important point of all of these evaluations is that we are really keen to understand the perspectives and the experiences of people with lived experience of homelessness who are in contact with the services, as well as the staff that will be delivering all of these services. So as part of the evaluation, we'll ask you to help us identify participants and staff to take part in some short interviews or some focus groups to really help us expand our understanding of the intervention and how we can make it even better in the future. Handing over to Graham or Rebecca.
Yeah, that's me. So I'm going to very briefly run you through our grant making process and kind of what to expect and what that might look like for you. So this is the grant making process we'll be following. What's most important is that there will be a 4-week window for you to make your application, and then that's followed by a 4 to 6 week review process of applications by CHI and then the Grant and Evaluation Committee. Next slide, sorry. So to manage all of this, we're going to be using Flexi Grants. That's going to facilitate the grant making process. You'll be required to register and log in, and then this will be how we manage the grant making process from the application right the way through to offer and even post offer. So the next few slides are just going to show you what you'll see and what to expect when you log in and kind of move through the process. Next slide. Yep. Okay, so this is you're a little bit ahead, Guillermo. But basically, this is what you're going to see when you're registered and logged in, and then you'll also be able to see the available grants on the programme, applications that you've begun, and your account details. When you go into the application form, there are a couple of key documents that I'd like to highlight. So firstly, there's the subcontract agreement that you will be asked to sign. Also available to you is the head agreement between CHI and DLUC, and then this sets out just some of the terms that we all have to follow. The information policy is there, it's referred to in the contract, and then also what will be there is the service specification, which will outline requirements and what we're kind of asking of you as per the project. So then next slide, Guillermo, thanks. And then, so this is just to show that there's guidance right the way throughout the portal to support you to complete your application. Next slide. So we're then we're really determined, you know, to make this as simple a process as possible. So there will just be 6 sections to complete, all within Flexi Grant, all sort of very user friendly and relatively light touch. Next one, yeah. So this is the notice that you'll see once you've successfully submitted your application, and that will be followed up with confirmation via email, and then obviously your application will come through to the review panel for and go through that process. Next slide. So here are those dates again that Guillermo shared earlier. So I suppose the key one that I'd ask you to really take note of is the 14th of May, which is when this project goes live on Flexi Grants. So that's when you would be able to begin your application, and then you have that 4-week window to complete that. And lastly, any questions?
Thanks, Rebecca. We could stop sharing. Yeah, that's cool. Thank you. So we've got a few questions in the Q&A box. If you've got any questions, now's your chance to put them in there. So just to clarify, although we talk about grant making when we talk about Flexi Grant, and it's called Flexi Grant, in a lot of the projects, money will change hands because you'll apply for money and you'll do a thing as a local authority or a provider. With this one, just to be absolutely clear, you won't get money. You'll get money because CGL are getting the money to employ the nurses. So what you're applying for is, please, can I have a nurse in my area? You won't get the money to employ one. So that's just to bear that in mind. There wouldn't be a need for you to provide a budget in this particular project. There is in some of the other ones. Okay. So in terms of questions, I'll start with a couple on the evaluation, if that's all right, Guillermo. So there's one from John which says, will the areas selected to pilot the project and be part of the control group be selected to be similar in terms of size, demographics and need?
That is the idea, yes. So we'll select 16 areas, and within those, if there are different groups where we feel that it's really important that we ensure that there's balance between the 2 groups, we will try to use that to ensure that the 2 groups are as comparable as possible. The really useful thing of randomizing in this case is that when the sample is big enough, you don't need to worry about those characteristics because the randomness of it basically ensures that the 2 sites are going to be comparable with each other.
Thank you. And there's a couple of sort of similar ways in which the same question has been asked about how many people should an area have? Like, what's the caseload or expectation around numbers? So do you have to have a certain number of rough sleepers to apply for a nurse? And what's that sort of expected throughput of clients that the nurse would work with?
We don't have a set number in this particular case, but of course, we need to have a conversation about whether you feel that it is the size of the population is sufficiently large to actually justify having a full-time nurse in those areas. So you definitely need to have a substantial caseload to make sure that this person has enough activity to actually work through, but also open to Leslie and Jassy if there's any views that you wanted to share on that front. But from an evaluation perspective, the more, the better. But also we have a period of 18 months, which will be sufficient in all of the areas we expect that would be put forward to really reach a really substantial number that will be satisfactory from an evaluation perspective.
Thanks, Guillermo. I don't know if Leslie or Jazz, you want to contribute in terms of how many people a nurse can comfortably work with in a given week. Probably differs depending on need, doesn't it? And the nurse.
I think the complexities probably will differ depending on the complexity, but I would say on average, probably about 20 to 25 people working with them quite intensively would be about right.
That gives you some sense of it, and they'll carry on working with people when they move off the streets into accommodation to ensure they don't return. And like you said, so I suppose it's like, it doesn't have to be like 25 physical bodies on the street that they're working with at that moment. It could be people that are in and out of rough sleeping too. So yeah, there's a question from Liverpool where there isn't a CGL service in Liverpool, but there are CGL services in surrounding localities. You'll know that yourselves. So would we be able to apply? So if we can just sort of cover off how we've been thinking about like locating the nurses to be able to enable them to support areas that don't have a CGL service. I don't know, Leslie, if that's one for you.
I think as long as we've got a sort of service nearby that we can place the nurse in. We did talk about one area where the nurse might, would be connected to the drug and alcohol service, and then it would sit with the outreach team. And I think it was about half an hour travel for the nurse. So as long as it wasn't too far for the nurse to be able to travel back and forth, I think, we'd definitely look at those areas.
Yeah. I think the important thing is apply if you think you need a nurse, apply if you think you've got the need locally that would benefit from that service and you don't already have one, put the application in. Then it's up to us really to figure out how we can make the intervention work if you're one of the areas that's selected. So don't let it put you off if you don't know whether there's a CGL service nearby or you don't think there is one. We'll do our best to make that work. We really just want people to apply. Some questions about the nurses and the qualifications. So I guess to address that to Jazz, perhaps more than anyone else, we talked at the beginning about them being a band 7 or the equivalent to a band 7, I think it's fair to say, isn't it? So there's a question about whether the nurses can prescribe treatment. And then there's a separate question about the sort of a question about what they can do, I suppose. Will they be able to work with physical health issues, or could they be CPNs, or what kind of experience or qualifications, or physical mental health expertise, in that kind of area? I think people are curious about the workforce.
Yeah, so I think we did say it was going to be equivalent of a band 7. So for us in Change Group Live, that is equivalent to a lead nurse. So as a lead nurse, not all of our lead nurses are prescribers now, they don't need to be. So we wouldn't put that in as a specification in this role. So they wouldn't have to be prescribers. But yes, they would be looking at all physical health needs. So all our substance misuse nurses currently would be doing things like ECGs, would be doing wound care, would be assessing physical mental health needs, would be doing ECGs, would be taking bloods, immunizations, referring for hepatology, any respiratory problems. So there would be expectation that they would continue on doing that. But depending on what level of experience they come across with, we are anticipating probably there'll be some internal CGL nurses that go for it, so they've got a drug and alcohol experience. And then in addition to that, we'll get more experience as part of their induction with the outreach teams as well, and the other outreach nurses that we do have as well. And the other part of that was, so is that both of them? Yeah,
whether they'd have the expertise, I suppose, to do physical and mental health
So if
they're
there
the
were,
most obvious issues they're going to be coming across in terms of the rough sleeping population. Yeah.
so there would you use different assessment tools to be assessing mental health and then referring on, or physical health as well.
Thank you. And as a sort of add-on question, I think someone asked what kind of clinical interventions the nurse would be able to deliver on the street, and will they have access to laboratory testing for pathology screening, which is very specific.
Yeah, so not all our services use hospital laboratory testing. So we go to a lab in Manchester, so they will have access to that. So depending on which service it is, they will have access to that. So all the bloods would be going there for testing. So they would have that because they will be linked to another hub. So we'll have access to do, for blood count, liver function tests, whatever blood that we need to be doing. But in addition to that, we'll also be doing things like dry blood spot testing for bloodborne viruses. They will be expected to be doing wound care as well, immunisation. So they will follow the cold chain policy and carry appropriate equipment in their medical bags to do immunisations for hepatitis B, for example. Also be giving out interventions such as naloxone. So I suspect it's really important for our population on the street, because they do need to have that to reverse the impacts of the overdose if needed to.
That's great, thank you. And then maybe a few questions for you, Rebecca, if you don't mind. So some questions about eligibility. So, could an area bid if they have a dual diagnosis worker, for example? I presume that's within an outreach team rather than just generally. And then someone else is asking if it's possible for the nurse to work with people like in housing first, or do they have to be a sort of rough sleeping population? So there's a couple of sort of eligibility questions, if you don't mind addressing those.
Yeah, so we are looking for outreach teams that don't have a health specialism already in place, regardless of what that is. So yeah, I think dual diagnosis and yeah, I think that would be too similar. As Guillermo said, it's really important that we're kind of testing this as a new intervention in an area rather than expanding on something that's already there. As far as housing first, we are looking at, obviously, because they're embedded within the outreach team, so we are looking specifically at working with people who are sleeping rough. Obviously, if there was somebody, I suppose, that was maybe had been referred to housing first and was just waiting for that to come through, I suppose they would still be able to be part of the intervention as long as they were still sleeping rough on a regular basis.
Thanks, Rebecca. And one sort of similar question is, someone has a sort of pathway into health services for rough sleepers, like a fast track access to healthcare, like mainstream healthcare. So they don't have anyone embedded in the outreach team. So I think the answer is they would be suitable. They're just lucky that they have fast track access to health services, but they don't have anybody embedded in the outreach team. So it's similar. Like, we understand, I think, that lots of areas have access to healthcare services for rough sleepers, sometimes a mobile bus, sometimes a sort of GP that's got a bit of an enhanced practice, sometimes like you, a pathway. But generally, the thing that we're testing is, do you have an embedded health specialist in your outreach team who's doing shifts and casework with rough sleepers? Is that right, Rebecca? So if the answer to that is no, they can apply regardless.
Exactly, yeah. Michelle, yeah.
Cool. I'd just like to answer that question myself for no reason whatsoever. So some questions about one for you, I think, Guillermo. You talked about sort of partnership bids, and as long as it was in the same health board. I think you meant like ICB region or ICS region, didn't you? Yeah, and I think that's just because of the data sharing and the capturing of data. So the important thing, I think, for that is, if you think about the nurse, she's one nurse, or he, I always say she, and I always catch myself when I do that. So if you're in the same ICB, I'm just thinking about somewhere like London, you could be in Havering, which is like the end of Essex, and you could be the City of London, and you're much more than 30 minutes apart, but you're technically in the same ICB area. So I think you need to consider, are you in the same health board area, but also are you geographically quite proximate to each other, because the nurse can't be travelling long distances. and there's a question there about rural areas and embedding a nurse in rural areas, particularly adjacent rural areas, to try and generate the amount of referrals and cases for a nurse to work with. So I don't know if Rebecca or Guillermo or indeed CGL colleagues have got a view about whether we could make that work if it was two large rural areas that had small numbers of rough sleepers but were willing to put themselves together to create the number of cases. Presumably that would be quite difficult for this model. I don't know who wants to answer that question.
I think it is a tricky one. I'm not sure what the answer is. I mean, I think we definitely want to engage with people that are in rural areas, because quite often people that are in those areas are not, you know, that they're sleeping on the outskirts of somewhere and they're not necessarily engaging with services every day. So they're the people that we really need to connect with, don't we, that are not coming into service, that are not engaging and seeing outreach workers all the time. So for me, I'd really love to be able to go out into those rural areas. I guess it's looking at whether that would work as part of the programme in terms of areas pulling together.
So,
yeah, sorry, just to expand on that, what would be really key, and is key to remember, is that they would have to be an outreach team already in place that is working across both of those areas already. So obviously without a health specialism attached. So yeah, and about the level of demand. So if you've got an outreach team that are working across both areas, I would assume there's reasonable demand for that service. So that wouldn't be problematic. But if you've got if you've got two areas but you haven't got an outreach team that covers both currently, then probably not.
yeah. And I think in all cases, I'm just going to say, because it's not an onerous application process, you're literally just saying, we are X local authority, we've got this many rough sleepers, we'd like to bid with our partner across the border here. We don't have anything, can we have one? It's not that simple, but it's relatively simple. I would say put in an application, because if you can make an argument that you can make it work, you could have a really good transport network in your area, and it could be possible for a nurse to get around the area and for that to work. So don't let it put you off applying. As part of the selection process, we'll look at that stuff and see if we can make it work. I misled you by saying that no money is going to change hands, and someone's picked me up on that in the questions. So of course, if you are selected to be in the randomised control group, you will get that 10 grand that Guillermo talked about. So there will be some cash changing hands. But in terms of if you're successful in getting a nurse, you'll get a nurse rather than cash. So yeah. Let's see, one more. So a question perhaps for Jazz, I think, or Leslie, both. How would the case management work in terms of recording information on EMIS?
Yeah, they would record on our caseload management system, which is CRIS. So it wouldn't necessarily record an EMIS, so EMIS is more GP led, or that's what the GPs would use. So they wouldn't be in GP surgery. So they wouldn't be, we don't use EMIS. So we use CRIS, and that's how they record the information on there.
Thanks very much. And then two last quick ones. I think one for you, Rebecca. Eligibility criteria, people pushing the envelope always, don't blame them at all. Do you think that people could be worked with in this service if they are in accommodation, but they have a history of rough sleeping, but they're technically in accommodation now, emergency accommodation? Or does the clients that are worked with have to be currently rough sleeping? I think you've answered it, but if you can just answer it again.
They would have to currently be rough sleeping and be engaged. Well, yeah, be engaging to some degree with the outreach team, as the nurse is going to be embedded within the outreach team. So yeah, they would be currently rough sleeping. And just to save a bit of time, I can answer the next question because I've already looked at it. Around, so given the relatively long timescales involved, there may be a retendering of the service delivery organisation for the outreach team. Would that be problematic? It wouldn't be problematic, as you said, as long as they agreed to the terms and they're able to host the nurse in the same way as agreed when set up. So that wouldn't be problematic at all. And no, this won't be, sorry, I'm literally on a roll now. I've got the question.
Go for it, Rebecca. I'm loving it, yeah. So redundant, but I'm loving it.
So the support, it won't be Would it be offered to rough sleeps that have been placed in TA? So I'm assuming where an offer has been made, but maybe people aren't staying in that accommodation or are still on the street. Yes, it would, if they're engaging and are interacting with the outreach team. Yes, that's
Yeah, I
fine.
think the important thing is to think that this is like to end rough sleeping, this initiative. And one of the key things that why DLUC chose this trial, why they're really interested in it, is particularly for those people with complex needs that can't be persuaded to accept services, persuaded off the streets, health degrading while they're on the streets. So if someone's already moved off the streets, they're already in TA, they're already in emergency accommodation, they're already engaging, there's an argument to be made for plugging them into mainstream health services rather than using this nurse. This nurse is about going out into the streets in antisocial hours, working with people that are quite entrenched and maybe a bit service resistant and carrying a caseload. They're not going to drop the person the minute the person moves into accommodation. So if the nurse uses all of their skills to get the person to accept some accommodation through building a relationship with them, it would make no sense for them to stop working with them at that point, because they'll carry that caseload. But if people are already accommodated, then they don't need this intervention, like you could argue, or they're not as in need of it as others. So if you think of it that way, they will work with some people while they're in accommodation, but not if they're already there. So yeah.
Could I just ask Michelle?
Yeah.
I guess it's a question from me, which maybe to know, but I'm just thinking a lot of people that we find rough sleeping have got accommodation, but are rough sleeping for various reasons and don't, you know, feel that they can return to their accommodation. We can still work with those people, can't we?
If they're rough sleeping, yeah, definitely. And like I said, some people will move into accommodation and out. They might go into sweat. They might go into a winter shelter for a bit and come out, but they're really long-term rough sleepers who resist. It's about trying to use the offices of a nurse and all the skills that they've got to be able to bond with someone over giving them healthcare to engage with them. Yeah. And then I think the last question, because we've only got a minute, but following on from the EMIS question, are results routinely sent to the GP? Thinking how this would work locally with health partners.
Yeah, so anything a nurse would do would be sent to GPs if the person has got a GP. Yeah.
Okay, cool. Thank you. So I think we might have to leave it there because we're running out of time. So thank you very much. Just to reiterate, the webinar is being recorded. It'll be put on the website. If you go to the CHI website, you'll see the project brief for this project, the timelines, the slides, and the webinar when we've managed to clean it up and put it on there. So you can look at that stuff again. Applications are opening soon. So put that date in your diary. You'll get an email if you signed up for emails to let you know when it's open. If you're not sure, you can speak to the programs team, to Rebecca, programs@homelessnessimpact.org. So that detail, I think, was in one of the slides, which we'll send out. So if you've got any questions after this, do ask. And get ready to put in an application and fingers crossed you get the nurse and not the 10 grand, I guess, in the randomised process. Thanks for attending. Thanks, everybody. Have a good day. Cheers now. Bye.